So our talk for this MEC minute is going to be on crush injuries, and this topic comes to the suggestions of our friends at Granville Fire. So crush injuries are something we've talked about in the past. We've had a protocol on the crush injuries, and it is a good time to start talking about crush injuries and how do we manage them, and as well as some other things we need to think about that are potential complications of crush injuries. So on our agenda, what we're going to talk about is crush injury versus crush syndrome. Injury results or could result in syndrome. We talk about complications, particularly of crush syndrome, but we are going to talk a little bit about compartment syndrome, which can come with crush injury. And we're going to kind of talk about treatment, breaking it out into pre-hospital care and emergency department care. Our key focus is going to be on that pre-hospital component of care. So when we talk about crush injury, I think most of us think about the things that are examples like on the left, which, one or two victims are involved in some type of accident. They have a crush to a body part, or they're pinned by something, in this case, a tractor. And we have one or two patients that we're going to evaluate, manage, and transport. Whereas, we often don't think about other parts of the country where there could be something bad happen, such as an earthquake, and then buildings collapse, and you have multiple victims who are crushed or pinned for long periods of time under the debris. We've been relatively fortunate in this country. Yes, we did have that episode in Florida when the condominium crashed. We had the big earthquake in California in 1989 with a lot of victims. But for most of us, when we talk about crush injuries, we think about the onesie twosies. Whereas really, if you talk about the big potentials for problems for us as providers, it's that MCI event where there are a bunch of people pinned underneath rubble. And it's not just getting them out, but what complications might they suffer from that crush. So I think it's important that before we get too far down the road, we really define what crush injury is versus crush syndrome. So crush injury is trauma to bones, soft tissue, muscles, and nerves caused by compression of the extremities or limbs. Yes, you can have significant crush injury to the trunk. Many times that is fatal. But we're talking about direct trauma to a body part related to compression, and it results in ischemia of that body part. So the body part is crushed. There's prolonged compression of the blood vessels. There's ischemia as a consequence because of poor perfusion. Crush syndrome is what can be a complication from prolonged compression as part of a crush injury. So crush injury, really, if you look at it, is injury to the body part that was trapped or pinned by whatever the material was. Whereas the crush syndrome is really more of a systemic manifestation of complications of that original injury. And it tends to come from prolonged compression. And we're talking about systemic damage that ultimately results in organ dysfunction or death throughout the body. So essentially, the crush injury results in immediate damage to the body part. Crush syndrome is a response to the toxins and to complications related to the original crush injury. For us, the most common organ dysfunction is acute kidney injury, which can be a big deal. So crush injury is that localized immediate event. Crush syndrome is the systemic complications of the injury. When you look at our crush protocol, with our protocol for infusion of fluids and bicarb, it really is intended to prevent the complications of the injury that could result in the crush syndrome. When did we first recognize this? Well, really, crush syndrome first was reported during the Battle of Britain. We had a lot of civilians that were pinned under rubble secondary to the bombing. The original reports were 5 people who were pinned. Upon extrication, they were found to have swollen extremities and dark urine. They all died. Really, what we're talking about here is crush syndrome with the manifestation of rhabdomyolysis. You have myoglobinuria or myoglobin in the urine, which turns the urine dark colored, and that myoglobin gums up the kidneys. You get acute kidney injury, acute kidney failure, and the patients die. So that was really the first episode, the first incidence. If you look at a lot of research, though, a lot of the research we have really comes out of those earthquakes. So if you look at earthquakes across the world by history, 2 to 15% of patients who are injured in an earthquake suffer crush syndrome. So they're pinned with by a body part, they are released, then they develop crush syndrome as a complication. If you look at that population of patients who develop crush syndrome, 50% of those with crush syndrome develop acute kidney failure. And of those 50% patients with crush syndrome, another 50% of that population need dialysis. So let's say on a worst case scenario, you have 1,000 victims. 15% of them develop crush syndrome, which means you have 150 crush syndrome patients. Half of them are going to result in kidney failure, which means 75% of the patients, or 75 patients of that 1,000, will have acute kidney failure, and about 37 of them are going to require dialysis. Now, if you think about what we can do in Columbus, I can tell you that it would be very difficult to us to just absorb 37 acute kidney failure patients across the metropolitan area. All of our hospitals have the ability to provide acute dialysis, but in the case of a mass casualty event, it would be difficult to absorb, in 24 to 72 hours, 37 more acute kidney failure patients who require immediate dialysis at our hospitals. This can be a big deal. And so common findings in these patients is acidosis because of that prolonged limb ischemia, hyperkalemia, potassium is released by crushed muscles, and patients also can develop hypocalcemia because the calcium is bound by the damaged muscle. So these are the common findings. These are the things we have to identify and treat. So as we talk about crush syndrome, what are the potential complications? So hypovolemia is a potential issue, and that could be because a patient could be pinned for 24, 48 hours. They may not be able to take oral fluids. They may be trapped and the rescuers can't get to them for a period of time, and they have no fluid intake, so they could be dehydrated. They could have injuries that result in hemorrhage and hemorrhagic shock. And they could also develop a distributive shock, meaning third spacing of their fluids because crushed tissue is swelling and absorbing all the available fluids. And so the patients basically don't have enough fluid in their body to keep a circulating blood volume. So they can develop hypovolemia and hypovolemic shock. Hyperkalemia is the one we always worry about, particularly in patients who are pinned and then we extricate. Hyperkalemia is an elevated potassium as a direct consequence of damage to muscles. Most of the potassium in our body is stored in muscles, and when the muscles are damaged, they leak potassium into the system, and patients can develop acute hyperkalemia. Acute compartment syndrome is something we have to think about. We have to start monitoring for it from the moment we extricate them. Acute compartment syndrome is where there's swelling of the muscles. The muscles are wrapped in that tight fascia, which really is not very flexible, and the pressures within the muscle compartments go up. That can impair circulation to the muscles, and they can develop dead muscles, which eventually can be a paralyzing issue. So they can develop acute compartment syndrome from direct trauma, but if we also aggressively resuscitate the patient, they can also have increased swelling with those muscle compartments and just from the volume that we give them. Rhabdomyolysis is what I mentioned earlier. Rhabdomyolysis is muscle breakdown. Myoglobin is like hemoglobin, but myoglobin is in the muscles. It has to do with oxygen carrying within the muscles. And rhabdomyolysis it results in release of myoglobin into the blood. The problem with myoglobin is it's filtered from our system by way of the kidneys, and if we have a patient who's hypovolemic because of shock, and they have myoglobin in their blood, it can be filtered by the kidneys. It can precipitate and form like a glue within the structures of the tubules of the kidney that filter, and you can get acute kidney injury as a consequence. And another complication of crush syndrome is acute respiratory distress syndrome. Chances are we will not see that in the field, but it's probably more of a complication to occur at the hospital. And ARDS can be due to a large volume fluid resuscitation. It can be due to our body's inflammatory response to the injury. It could be direct lung injury from hypovolemic shock or from hemorrhagic shock. That can directly contribute to acute respiratory distress syndrome. Another potential complication is if you have long bone fractures secondary to crush, it could cause fatty material from the bone marrow to be released into the bloodstream. That can cause fat emboli, which can become plugged up in the lungs, and it can cause lung damage because it can block the capillaries of the lungs, resulting in direct lung injury as well. So ARDS is real, it's out there. We are more likely to see it in the emergency department or after the patient's admitted to the hospital, but it's something we think about. What is our mortality? Well, early in the phase of crush syndrome and crush injuries, the immediate causes of mortality are hypovolemia either from hemorrhagic shock or because the patient's dehydrated, has inadequate amount of fluid intake, or due to hyperkalemia. And hyperkalemia is the one thing that we worry about when we have a patient who's pinned, and now we're going to release their pinned body part. How might we release that potassium? Or, the muscle is now damaged. There's potassium being leaked out. We now perfuse that body part, and that potassium is being washed out into the general circulation where it's available to cause problems. Later in the course of the injuries and crush syndrome, patients can develop sepsis because they have an infected body part. This type of injury makes patients more susceptible to infection, and they can develop acute sepsis. And the other late complication is multiple organ failure. So you can have kidney failure resulting in death. You can have injury to the lungs from fat emboli with ARDS resulting in death. But the later in the course, it tends to be multiple organ failure that results in the patient's demise. So I brought up hyperkalemia. I think this is an opportunity to talk a little bit about hyperkalemia and electrocardiograms. Hyperkalemia, when we look at the EKG, we look for things like PT waves. We look for things like QRS duration that's prolonged. We can see an increased PR interval, and we can also see flattening of the P waves. So these are two different EKGs, both the patients with hyperkalemia. And the first thing you can see here is you get these big, tall, peaked T waves. Now, we have to admit, though, that some patients have peak T waves normally, but if you have a patient who's crushed, you put them on a cardiac monitor, you extricate them, do a 12 lead, and you see big T waves, that's presumed to be due to hyperkalemia until somebody proves otherwise. You're not going to prove otherwise in the field. We need a blood test at the hospital. So if I see that in the field after a crush injury, I'm going to immediately be concerned about hyperkalemia and start treatment. The other thing we can start seeing is you start seeing the QRS duration prolong. So it's well past 0.12 milliseconds. The QRS duration gets wider and wider. And as things progress, you can see the QRS durations in this other EKG on the right. Now, my last arrow that I popped up there shows P wave. There's a flattening of the P wave. It's not as good as previous. Sorry about that. I got a phone call. So getting back to the previous slide, the P wave tends to be flattened. You have an increased PR interval with evidence of fairly substantial first-degree heart block. So the 12-lead electrocardiogram can give us a lot of useful information when looking at these patients, particularly post-extrication. So getting back to how do we treat the patients? Well, the key for us is going to be fluid resuscitation and decreasing the risk of hyperkalemia. And if you look at the protocol we have, that's what the focus is on. If you look at the recommendations from the kidney groups, they are all about fluid resuscitation, particularly before the patient is extricated. So for us, treatment in the field of crush injury patients is going to focus on fluid resuscitation, treating the patient with bicarb to reduce or decrease the risk of hyperkalemia, and to potentially correct acidosis. And then the other thing we want to do is start treatment early to prevent precipitation of myoglobin in the kidneys. For most of us, how we treat that problem with myoglobin is fluid resuscitation and bicarb, and we'll talk about that in a couple minutes. So for the things that we need to worry about as immediate threats and future threats to the patient related to the crush and crush syndrome, it's all about fluids and bicarb. So if you talk about our pre-hospital treatment, ABCs always come first. Any injuries to the face and chest may require supplemental oxygen. You may need to provide airway support. If the patient is in a situation where there's crush injury, but there's also heat and smoke, you have to worry about airway edema, and you need to think about things like should I give the patient cyanotic kit or whatever else. But ABCs come first. If you have patients with crush injury to the chest, then you need to be aware of, what complications come with that. Could it be a flail chest? Could it be a pneumothorax? Could it be a tension pneumothorax? Do you need to decompress the chest as part of your initial assessment? In terms of the crush injury and how we're going to manage that injury, our goal is to start rapid fluid resuscitation, and that's key to the treatment. And the current recommendations are for at least a liter of fluids per hour of normal saline for 2 hours, and then run it at 500 cc's an hour. If you have patients who have CHF or COPD or chronic renal disease, the recommendation is you just give them 10 milliliters per kilogram per hour. But for the most of our patients, particularly since we don't know what their past history is, we're going to give them a liter of fluids, a liter of normal saline per hour for 2 hours, for that first 2 hours of care. If the patient is still pinned, you then drop it down to 500 cc's an hour. But you want to maintain fluids. What else do we do? Well, when we get the patient out, you have to think about things like pain control. We have to think about avoiding hyperkalemia that may induce VF, and that's where bicarb comes in. But again, IV fluids are the mainstay of treatment. There really is no role for tourniquets or field amputation to prevent crush syndrome, at least in the field for us. If the patient has a severely mangled extremity that is not salvageable, surgeons may do an amputation in the hospital. Now, if you're talking about field amputations, it's not in scope of practice for paramedics or any EMS providers in Ohio, so don't start thinking about that. But if you happen to have a physician on scene who's going to do an amputation, then the field tourniquet may be appropriate in order to control bleeding as part of the procedure in the field. But for what we do in the field, putting a tourniquet on to prevent limb reperfusion, to prevent crush syndrome, is not considered an appropriate means of treatment. Use the tourniquet if you need it for bleeding control, but don't use it to prevent crush syndrome. Well, I keep talking about the kidneys. Well, there's a group out there called the Renal Disaster Relief Task Force, or RDRTF, and they have recommendations for management of crush victims and mass disasters. As I mentioned in the earlier slides, we think about the onesie, twosie victims, but for a lot of the crush injuries across the world, they're related to mass casualty events where there's collapse of a building or some other structure and people are pinned. Earthquakes tend to be the big offenders. Bombings, another one. You can see crush syndromes more in the war situation like they saw in Great Britain. But this group has specific recommendations, and I'm going to talk about that and contrast it to what we do as part of our protocol. Okay, so this group, the RDRTF, recommends sodium bicarb for forced alkaline diuresis. What that means is we give the patient bicarb to make their urine more alkaline or more basic. When the urine is basic, when the urine is more alkaline, myoglobin doesn't precipitate and gum up the kidneys so much. So, we try to give patients a lot of bicarb to alkalinize their urine. So their recommendation is to treat the patients with 1 to 2 liters of normal saline, and then start them on an infusion of 0.45% normal saline plus 50 milliequivalents of sodium bicarb, which is 1 amp, and run that at a generous rate based on their fluid recommendations. Again, their goal for a urine pH is over 6.5. That means somebody is taking a urine sample, testing the pH. That's not something we'll do in the field. That is something we will do in the hospital. And also stop the infusion of bicarb if the blood pH goes over 7.5, which is done through a blood gas test. Again, not something you do in the field, but those are the things we use in the hospital to monitor our sodium bicarb infusion rates. So how do we put that together? Well, here's that group's recommendations for pre-hospital care. They have algorithms for hospital care, which I did not want to bore you with. So basically, if we're talking about a victim is under the rubble, before you extricate the patient, can you start an IV or not? If you can't start an IV, you don't give fluids. If you can get an IV before extrication, you give the patient 1 liter of fluids per hour. If once you start extrication, you continue to give them the fluids, and after the first 2 hours of fluids, after the first 2 liters of fluids at 1 liter per hour, we will then drop the infusion rate to a half a liter or 500 cc's per hour. After extrication, we want to continue saline infusions and up to 3 to 6 liters over 6 hours, and then check the patients and their urine output. So urine output is an important indicator for us in terms of adequacy of hydration, adequacy of volume and fluids. That's why critically ill patients in the hospital get a Foley catheter. Urine output is a good measure of how well the patient is being resuscitated. So that's their protocol. Here's ours. So, if you look at our protocol, I kind of pared it down. Our goal is to have at least 2 IVs started pre-extrication. We're going to start them with a generous infusion of bicarb with saline. So we only carry saline. If we put an amp of bicarb in normal saline, the patient is going to get a bit of a hypertonic solution, but they're getting bicarb. You could make an argument that, well, we'll just give them saline and then give them bicarb as a push. Well, you're giving them just as much sodium. So we're going to start them on bicarb with an infusion. And then once we get them out, we're going to continue our aggressive fluid resuscitation at 20 cc's per kilo per hour or higher as necessary to keep their systolic heart rate up. And we're going to watch the QRS duration and watch the T waves on the monitor. If the patient starts developing widening QRS complex or they start showing evidence of VTAC, we may give them additional bicarb, even if we've already preloaded them with bicarb. So bicarb would be the answer for this. You can also make an argument to treat these patients as if they were in renal failure, where we use bicarb and calcium. If you have that type of an issue where the patient's had a prolonged extrication, you've given them the bicarb, you've given them the fluids, and now they're starting to show funky rhythms, call me. We'll talk about giving them calcium. You should have calcium on the truck as part of our resuscitation. But currently, as part of our protocol, we don't have automatic treatment with calcium if they're developing widening QRSs. The treatment for you is going to be bicarb and fluids. What do we do in the emergency department? We're going to continue the ABCs. We're going to continue to give normal saline. We're going to watch the urine output through a Foley catheter. The goal is to have a urinary output of 200 to 300 cc's per hour. That's a pretty good amount of urine. We're going to continue this high flow, high urine output state until any concerns about myoglobin in the urine have resolved. Typically when myoglobin starts really showing up in the urine starts getting dark. And then we're going to monitor the patient for hyperkalemia. So if we see changes in QRS, changes in T waves, if the patient's chemistry show elevated potassium, we're going to start treatment with bicarb, calcium, albuterol. Nebulized is a part of treatment for hyperkalemia. And those are the things that we're going to do. We may also add dextrose and insulin because that drives potassium back into cells. Importantly, another thing we're going to do is we're going to watch this patient for acute compartment syndrome, which we'll talk about on the next slide. That's where you get the pressure buildup within the muscle compartments of the extremity. We typically think about acute compartment syndrome in the lower leg, but it can happen in the thigh, it can happen in the arm. We always watch for compartment syndrome, and there's a way for the orthopedist to measure the compartment pressure with a needle and a monitor gauge. We're going to follow the patient for kidney injury. And probably going to get dialysis started early if they show progressively worsening renal function. The nephrologist will come in and get them started anytime if it's appropriate and indicated. And then we'll watch the patient for ARDS. We'll give them ventilatory support, whether that's BiPAP, whether it's intubation, or any of the other treatments for ARDS. I want to talk briefly about compartment syndrome. Compartment syndrome is that increased pressure within the compartments of the muscle. We talk about the 5 Ps of compartment syndrome with paresthesia, pain, pallor, pulsiousness, and paralysis. Paralysis is typically the last thing we see. Paresthesia is typically the first. The patient, could be a little lady fell down, lay on her leg for 6 hours before somebody helped her up. So paresthesia is a loss of sensation in the distal extremity is what we look for. And they often lose 2-point discrimination, meaning if you take 2 pins and touch them, half a centimeter to a centimeter apart, they may not be able to tell you if it's 1 pin or 2. They lose that ability to discriminate. That is a very sensitive indicator of early compartment syndrome. Another symptom we think about is pain that's out of proportion to injury. Patient who's complaining of severe leg pain and you don't see much injury, we start thinking about compartment syndrome. Pallor or pale extremity is another consideration. Pallor and pulselessness are later manifestations. If this patient has a pale, pulseless foot, we are worried about a compartment syndrome. We're going to get the orthopedist en route, and they're going to need to take the patient to the operating room. Paralysis is a late stage of compartment syndrome, and if the patient's got paralysis from compartment syndrome, it's unlikely they're going to regain full motor function with appropriate treatment. So think about paresthesias, numbness. They can't discriminate between two touch points. Think about pain that's out of proportion to injury. Think about the pale and pulseless foot, and then again, paralysis is a late player. The treatment's fasciotomy, which is what you see here. Surgeons go in, they open up the skin, and then you can see below the retractors where the surgeon has taken the scalpel and cut through the fascia of the 2 compartments, the anterior and the lateral compartment of the lower leg. And that basically allows the muscle to just swell, but it relieves the pressure. And they'll just leave it open. And then they may close this at another time, or they just may let it heal in with skin grafting at another time. But this is compartment syndrome. It's always something we have to think about. Always think about it in the folks who've been down, who've been lying on a body part for a long period of time. They are at high risk for compartment syndrome. The last thing I want to talk about is traumatic asphyxia. It's type of a crush injury. We're talking about patients who have crush to the chest and they can't breathe well, and they may have increased intrathoracic pressure, which means they don't have great venous return. They can develop this violet colored skin. You can see edema of the face. You can have subconjunctival hemorrhages. If you open up the eyes, you can see petechiae, which is the little red spots about the face. Those are all things concerning for severe thoracic compression. For us, the most common circumstance for us is probably going to be the person who's working under their car. They're not using an appropriate jack. They don't have any blocks under the axle, and the car drops on the patient, and you find them there crushed between the ground and the automobile. That's our most typical presentation for traumatic asphyxia. But it could be a building, it could be a beam. We don't know. And death occurs quickly. These patients don't do well because they can't ventilate, they can't circulate. So in summary, crush injury can result in crush syndrome. So if you have a crushed body part, think about potential complications of that localized crush. Consider other potential injuries. So the patient may have rolled over in the tractor, their leg is now trapped under the tractor, but could they have a neck injury? Could they have something else going on? ABCs always come first. And scene safety. So, make sure the scene's secure, and then treat the ABCs. In terms of crush, for us, the treatment centers on fluid resuscitation, and that's very aggressive fluid resuscitation. We use sodium bicarbonate to treat hyperkalemia and prevent rhabdomyolysis. And then post-extrication, we need to evaluate and reevaluate for compartment syndrome. So if you have a body part that's trapped, you get them out. They're not complaining of, the leg doesn't look bad, the body part doesn't look bad. Check the pulses at least twice. It's kind of like vital signs. You need one at the time of assessment. You need one before you arrive at the hospital. It's nice to have 2 sets of vitals. It's nice to have 2 evaluations of the injured limb for evidence of compartment syndrome to see if there's been any progression. So always think about compartment syndrome and reevaluate. So that's it. I thank you. Next month will be November. Probably in November, we'll talk about a topic to go over some of the changes the protocol. We may do that November, may do that December, but for sure we'll have the protocol review before the end of the year. Thank you.